Hello, my name is Ryan Stevens, and I'm an infectious diseases and antimicrobial stewardship pharmacist at the Mayo Clinic in Rochester, Minnesota. Today, I have the pleasure of reviewing the new utility of an old therapy in a discussion of the pertinent information surrounding convalescent plasma as it applies to the treatment of SARS-CoV-2. The mechanism of action with the utility of convalescent plasma in SARS-CoV-2 infection involves the adaptive or humoral immune system. In this system, the host develops pathogen-specific antibodies after exposure to an antigen. These antibodies then act to allow for neutralization and clearance of the infecting pathogen. This is predominantly accomplished via two mechanisms. First, active infection and survival. In this circumstance, an active infection confers immunity to future infection with the same pathogen for the duration by which the antibodies are present. This will come up several times throughout the course of this presentation, but seroconversion from a negative status to a positive antibody status in SARS-CoV-2 has been shown to take place somewhere between 8 and 21 days, depending on the specific antibodies. When we look at these antibodies, we see seroconversion to an antibody status happening at a median time of 11 days, with IgM and IgG specific seroconversions happening at median times of 12 and 14 days, respectively. The second mechanism by which adaptive immune system can be activated is vaccine, whereby an intentional exposure to an attenuated form of the pathogen or antigens of a pathogen stimulate the immune system to produce antibodies without the requirement for the host developing an acute infection. Vaccine development for SARS-CoV-2 is currently underway. However, in the interim, the study of convalescent plasma is gaining traction as a method by which to boost the adaptive immune system of an infected patient. In convalescent plasma therapy, the plasma of a patient who has previously been infected and survived, thereby having developed these adaptive antibodies as the activation of their adaptive immune system, is harvested by apheresis. This plasma from this patient can then be administered to another acutely ill patient, and the resulting effect is the horizontal transfer of passive immunity. The duration of this passive immunity will vary depending on the neutralizing titer threshold of the pathogen and the half-life of the transferred antibodies. However, in SARS-CoV-2, we're estimating that passive immunity may last for between weeks and months, thereby helping a patient to recover through the acute illness themselves and hopefully undergo seroconversion for future protection by activating their own adaptive immune system. As previously mentioned, seroconversion is estimated to take place between 8 and 21 days in patients with COVID-19. This study evaluated the serologic conversion profiles of 41 patients with COVID-19. For immunoglobulin detection, they used ELISA with both nucleocapsid and spike proteins. This test had a sensitivity and specificity of 90 and 95% respectively for IgG detection and 80 and 95% respectively for IgM detection. IgG seroconversion took place at a median of 11 days with a range of 8 to 16 days and peaked at 30 days. They also found that critically ill patients had a steeper IgG response curve. IgM seroconversion had a wider range and was less predictable than IgG. Specifically, patients' IgM seroconverted in 14 days with a range of 8 to 28 days. It then peaked at 18 days and then declined. This is also consistent with data regarding IgM seroconversion from patients with SARS-CoV-1. This study confirms that IgM will likely be of very little utility in tracking the disease and that IgG may be the best immunoglobulin target. The reason that I say that convalescent plasma is one of the newest, oldest therapies for COVID-19 is that it may just be coming to light for the treatment of SARS-CoV-2. However, the practice of convalescent plasma administration dates back as far as 1892 when it was used in the treatment of diphtheria. Over time, there have been a lot of diseases that convalescent plasma has been explored for, and notably, it's generally been the primary therapy for some infections prior to the antibiotic era. However, most recently, sort of since 2000, the year 2000, convalescent plasma has been explored for the treatment of 4 specific viral diseases: H1N1 influenza, Ebola, and 2 novel coronaviruses, SARS-CoV-1 and MERS-CoV. Through the use of convalescent plasma in Ebola in 2015, we didn't see this prove to be an effective therapy. However, the outcome in the treatment of influenza A, H1N1 in 2009, and more notably the other 2 coronaviruses mentioned above, SARS-CoV-1 and MERS-CoV, we have seen the demonstration of some positive outcomes. Though it's beyond the scope of this presentation to explore each one of these listed in this slide individually, I think it's important that we examine the activity of convalescent plasma in the treatment of coronaviruses specifically a little more closely, as it will help shape some of the discussion surrounding the use in SARS-CoV-2. First, I think it would be important that we examine the utility of convalescent plasma during the SARS-CoV-1 epidemic in 2003. During this epidemic, convalescent plasma was utilized in 80 patients in Hong Kong in the treatment of SARS. They administered between 1 and 3 units, which equates to 160 to 640 milliliters of convalescent plasma, and evaluated the primary outcome of discharge by day 22 post-convalescent plasma infusion. They found that of the 80 patients that were administered convalescent plasma, 33 or 41.3% were discharged by day 22 post-infusion. And when they evaluated the factors which appeared to contribute to a favorable outcome, they identified 2 key findings with regards to the patient improvement on therapy. First, they found that patients who received convalescent plasma within 14 days of symptom onset experienced a higher rate of favorable outcome. Specifically, 56% of patients who did experience a favorable outcome, which remember is discharged by day 22 post-infusion, had received therapy within 14 days of symptom onset. This is compared with a rate of administration prior to day 14 in only 15.6% of patients who experienced a poor outcome. The second key finding was that patients who were PCR positive but seronegative for SARS-CoV-1 antibodies at the time of convalescent plasma infusion seemed to be more likely to respond. This is demonstrated by the fact that 61% of patients in the good outcome group, as compared to 21% of patients in the poor outcome group, were found to be PCR positive but seronegative at the time of infusion. It is, however, important to note that the definition of seronegativity was not clearly defined in this study. Of course, these 2 findings are not totally independent. Patients early on in the course of infection are also more likely to be PCR positive and seronegative, thereby sort of linking these 2 factors and providing an explanation for each. And this could be important as we consider the use of convalescent plasma in SARS-CoV-2, where we know that there appears to be an acute viral phase of the illness, followed by a later immune activation phase. Additionally, we know that seroconversion in SARS-CoV-2 infected patients generally takes place between 8 and 21 days following symptom onset. So though much still remains unknown, it could be hypothesized that similar to SARS-CoV-1, specific early administration to seronegative patients may be a future direction for research and could potentially provide the greatest amount of benefit. Next, let's look at what is known from the MERS-CoV outbreak. This study outlines the use of convalescent plasma in 3 patients in respiratory failure due to MERS-CoV infection. All 3 of these patients were administered between 1 and 2 units of convalescent plasma and observed for early seroconversion following therapy. The convalescent plasma was obtained from 4 separate donors with varying titers of neutralizing antibodies, and though all patients recovered, only 1 of 3 experienced early seroconversion. This patient was also the only one to receive plasma from a donor who had a neutralizing antibody titer of greater than or equal to 1 to 80. This study, though small and limited, it yields an important point, which is that the donor antibody titer may play a key role in the level of success that we observe with convalescent plasma therapy. This will shape future discussions around convalescent plasma administration in SARS-CoV-2 later on in this presentation. When considering the data specific to SARS-CoV-2, there are no randomized clinical trials with current data available, although the studies are underway. What we have is 2 small, uncontrolled trials and 1 case series, which were all performed in China. First, by Duan et al., involved 10 patients who were 18 years or older, admitted with severe COVID-19, which was defined in this case as either a respiratory rate greater than or equal to 30, oxygen saturations less than 93% on room air, or a PaO2-FiO2 ratio of less than 300. Interestingly, this study excluded cases with serious general conditions such as severe organ dysfunction who were not suitable for convalescent plasma transfusion. The median time between symptom onset and hospital admission was 6 days, and the median time between symptom onset and convalescent plasma administration was 16.5 days. All patients in this study also received concomitant antiviral therapy, and 6 of 10 received methylprednisolone. The convalescent plasma treatment that was administered in this trial consisted of the administration of 200 mL of plasma from donors with neutralizing antibody titers of greater than 1 to 640. In the results, they describe an improvement in clinical symptoms and radiographic findings. They also show a tendency towards decreases in inflammatory markers. They did not observe any deaths in the study, and neutralizing antibodies were available for analyzing in 9 of 10 patients. Increases in titers were seen in 5 of 9 patients, and stable titers were seen in 4 of 9 patients. The second study outlined by Shen et al. Describes the utility of convalescent plasma in 5 adult patients admitted with severe COVID-19 that were critically ill. Their specific definition for critical illness and severe COVID-19 was progressive pneumonia despite antivirals, a PaO2, FiO2 ratio of less than 300, or mechanical ventilation at the time of study enrollment. The median time between symptom onset and hospital admission was 2 days, and the median time between symptom onset and convalescent plasma administration was 20 days. All patients in this study also received concomitant antiviral therapy, and all patients also received methylprednisolone. The convalescent plasma regimen that was used in this study consisted of the administration of 400 milliliters, or 2 200 milliliter infusions, of plasma from donors who were required to have an IgG titer of greater than 1 to 1,000 and a neutralizing antibody titer of greater than 1 to 40. The results that were observed were a normalization of body temperature within 3 days in 4 of 5 patients. Decreases in SOFA scores and increases in PaO2, FiO2 ratios were seen within 12 days. 3 of 5 patients were extubated within 2 weeks, and acute respiratory distress syndrome resolved within 12 days in 4 of 5 patients. They also noted that viral loads were decreased and became negative in all patients, and this was measured by a PCR cycle threshold of 40 for swabs collected from the nasopharynx. They also noted an increase in recipient neutralizing antibodies, and all patients were still alive at the time of publication, with 3 having been discharged and 2 currently in stable condition. The third paper we'll discuss was a series which was recently published in Chest. They reported the use of convalescent plasma in 4 adult patients ranging in age from 31 years to 73 years. The median time between symptom onset and hospital admission was 4 days, and the median time between symptom onset and administration of convalescent plasma therapy was 12.5 days. These patients were all critically ill at the time that convalescent plasma was administered, and they all received varying doses ranging from 200 mils as a single unit in one patient to 2,400 mils as 8 separate units over a 26-day period in another. The authors did not comment on the donor characteristics or the associated antibody titers from either the specimen or the donor. None of the patients died, and all 4 were reported to have experienced positive clinical and virologic outcomes, although these varied in each case. These 3 studies are encouraging. However, the lack of control groups in all should cause us to interpret them and apply them cautiously as we move forward exploring convalescent plasma. Recently, a study was published looking at the clinical efficacy of convalescent plasma for the treatment of COVID-19 in a multi-center design. This was performed in Iran and was prospective and observational in nature, where they compared convalescent plasma in conjunction with standard of care to standard of care. They infused a 500 milliliter plasma transfusion times 1, and that was followed by a second dose at the discretion of a physician if they didn't note any clinical improvement within 24 hours. Of important note, this transfusion had to be administered within 3 days of admission in order to be eligible for inclusion in the study. The plasma that was transfused was collected from donors between ages 18 and 60 that had to be asymptomatic for 14 days, but had been previously PCR positive and PCR negative at the time of donation. This plasma was also tested for IgG levels, or IgG positivity using ELISA. And they found that 98% of donors were positive for IgG and 75% of donors were positive for IgM. However, they didn't report the specific antibody titers. The inclusion criteria for the study included patients that were greater than age 18. They had to have the confirmed presence of COVID-19 and symptoms. They had to have an oxygen saturation of less than 93% on room air, and they had to have less than or equal to 7 days since illness onset. Patients were excluded if they were intubated, had severe liver or kidney disease, were found to be in septic shock. A physician had the opportunity to exclude them based on their discretion, and patients with improving clinical condition who were meeting discharge criteria were also not included in the study. So a couple important notes is first, again, just to reemphasize that these patients were within 7 days of symptom onset, and they also had to receive their plasma transfusion within 3 days of admission. What they really basically looked at was the use of convalescent plasma in what we would define as severe disease, but they excluded those patients who would have life-threatening disease. Here you can see the outcomes that were observed in this trial. As you can see, all-cause mortality was numerically lower in the plasma group as compared to the control group, but this did not reach statistical significance. The length of stay, as demonstrated by a mean plus minus standard deviation, the percentage of patients achieving a length of stay of less than or equal to 5 days, and the percentage of patients who did not require intubation all favored the convalescent plasma arm. Now, the authors do note that they did have some limitations to their study, including the lack of randomization. They specifically said it was difficult because patients had to be matched and typed for convalescent plasma, and if a match or type was not found within 3 days, then it inhibited their ability to be included in the active wing of this trial. Also, they note that concomitant use of antivirals was permitted, which seems to be a relatively common confounding factor in most COVID trials, including those with convalescent plasma therapy. Another new trial evaluated the efficacy of convalescent plasma therapy on specifically the time to clinical improvement in patients with both severe and life-threatening COVID-19. This was an open-label, multi-center, but randomized clinical trial that took place in 7 hospitals in Wuhan, China. The time course was between February 14th and April 1st of 2020, and they enrolled 103 adult patients with severe or life-threatening COVID-19 who were not enrolled in other active clinical trials. They had originally planned to enroll 200 patients, but given low enrollment numbers and declines in disease prevalence in the area, they decided to close the study early with 103 adult inpatient inclusions. This included 52 patients in the convalescent plasma group and 51 control group patients. I've listed the exclusion criteria here, and I'm not going to read all of them for you, but I will note that it's a relatively lengthy list. And so it is definitely worth paying attention to specifically things like severe sepsis and also other contraindications that were determined by the patient's physician at the time of enrollment or evaluation for enrollment. Donors for the convalescent plasma used in this study had to be between 18 and 55 years of age. They had to have had lab-confirmed COVID-19 and recovery, which was defined as being asymptomatic for at least 14 days. And they had to have measured IgG antibody titers specific to SARS-CoV-2 of greater than or equal to 1 to 640. The dosing that was used was 4 to 13 milliliters per kilogram of recipient body weight, and the primary outcome that was evaluated was time to clinical improvement within a 28-day period. Their secondary outcomes included 28-day mortality, discharge by day 28, and conversion of the PCR from positive to negative at the time interval of 24, 48, or 72 hours post-transfusion. Specifically, they found that with regards to clinical improvement, there was no difference between the two groups, although it did appear to potentially favor numerically the convalescent plasma group. Even more, when we dive into the outcomes of this study, we find that there was a better effect in patients with severe COVID-19 versus life-threatening COVID-19. And this was demonstrated by both the percentage who experienced improvement by day 28 and the time to improvement. So if we look at the severe disease patients, the primary outcome of clinical improvement by day 28 was observed in 91.3% of patients receiving convalescent plasma versus 68.2% of patients not receiving convalescent plasma, for a hazard ratio of 2.15 that was found to be statistically significant. Conversely, if we look at the life-threatening disease population, 20.7% of patients were asymptomatic by day 28 in the convalescent plasma group versus 24.1% of patients in the control group, which did not reach statistical significance. Also, they found that in the severe group, they tended to have faster time to clinical improvement by 4.94 days. 28-day mortality specifically demonstrated no difference. Discharge by day 28 demonstrated no significant, but rates of negative conversion of the nasopharyngeal PCR was higher in the convalescent plasma group at all time points, including 24, 48, and 72 hours. Notably, only 2 patients of the 52 that received convalescent plasma therapy experienced adverse events in this study. One was a rash and chills that resolved with steroids, and the other was within the life-threatening COVID group, experienced shortness of breath, cyanosis, and dyspnea within 6 hours of transfusion, and this resolved with the administration of dexamethasone also. All in all, the study didn't find statistically significant improvement in many of the outcomes that they looked at, but was likely underpowered to do so given early trial termination. And there were several numerical favorings for the convalescent plasma group, specifically in those with severe disease. And I think that's an important finding that also sort of mirrors the finding of the Iranian study that we previously evaluated. And so moving forward, perhaps it's been theorized based on this study that there may be a greater benefit to using convalescent plasma in patients with severe disease as compared to those with life-threatening disease. In the May version of this webinar, I highlighted a Cochrane meta-analysis that looked at the use of convalescent plasma in SARS-CoV-2. This is an update to that meta-analysis, which now includes 20 studies, 5,443 patients. However, they still note that the overall risk of bias is high due to study design, the type of participants that were included in these studies, and concurrent or previous antiviral therapies. They looked at 3 outcomes with regards to efficacy, including mortality, symptomatic improvement, and time to death. They're very uncertain whether convalescent plasma has an impact on any of these outcomes, again, primarily owing to very small studies and that are both randomized and or controlled in nature. With regards to safety, they included 14 studies. This includes one study that contains 5,000 patients, which is an evaluation of the National Expanded Access Program that we'll go into in more discussion later on in this presentation. However, they're also uncertain whether convalescent plasma is associated with serious adverse events, and this owes to a few things as well. Very few of the studies that report on adverse events actually grade the severity of the adverse event, but rather just classify the number of serious adverse events that were observed. Specifically, the study that we'll look at a little bit later that included 5,000 patients only looked at the risk of serious adverse events within 4 hours of transfusion. And so our ability to fully understand the scope of adverse events, though most likely would be accompanied right next to the transfusion, is somewhat limited in that nature. The group also noted that there were 98 ongoing studies of convalescent plasma or hyperimmune immunoglobulin, 50 of which were randomized in nature. So obviously there's much more to come on this topic. I want to preface this slide and this study by stating that as of the 1st of September, this has not been formally peer-reviewed or published, and it's currently published only as a preprint on the medRxiv website. However, given the critical nature of this study to the August 23rd emergency use authorization, I found it important to include here. This study, titled The Effect of Convalescent Plasma on Mortality Among Hospitalized Patients with COVID-19, Initial 3-Month Experience, was exactly what it describes as a 3-month summary of the data from the National Expanded Access Program. Specifically, the dates included were April 4th of 2020 through July 4th of 2020. As such, this was an open label study which was not randomized or placebo controlled. And it's worth noting that this is generally the nature of data that can be expected to be retrieved from an expanded access program. The expanded access program was initially designed to expand access to plasma for those unable to participate in clinical trials and to evaluate the safety of this treatment. Their initial goal had been to enroll 5,000 patients. However, this was expanded between April 4th and July 4th, and they actually enrolled 36,226 patients who were actually enrolled and transfused as part of the expanded access protocol. The goal of in total, 47,047 patients were enrolled in the expanded access program during the defined dates. And of these, as previously mentioned, 36,226 were transfused with plasma. And of these, 35,322 had adequate data to be included in the analysis. The patients were further split into 3 time courses consisting of roughly 1 month in each subgroup. This was done to account for changes in patient characteristics or concurrent management strategies as the pandemic progressed. In total, 3,082 patients were transfused with plasma for which antibody levels were known, and they only received 1 unit, making them eligible for the antibody level analysis. Patient enrollment across the 3 time periods is also listed for your information on this slide. It's interesting to note that by splitting the patients into 3 windows during the early phases of the pandemic, like this, there's some differences that are observed between the severity of illness and concurrent therapies between the groups. Specifically, patients enrolled early on were more likely to be critically ill and receive concurrent therapy with hydroxychloroquine and azithromycin, versus patients later in the group or later in the analysis who are more likely to receive concurrent remdesivir and less likely to be critically ill.
With regards to early administration, it was observed that those patients who received plasma transfusions within 3 days of their diagnosis had lower mortality rates at both 7 and 30 days as compared to those who received transfusions more than 3 days from diagnosis. It's again important to note that the time to transfusion was measured from the time of diagnosis to transfusion and not the time from symptom onset to transfusion as had been performed in some previous studies. When considering seroconversion timing, one plausible explanation for this finding would be that by transfusing those earlier in the course of their illness, you may allow for transfer of passive immunity to those who had not yet seroconverted, and thereby provide antibodies to a patient population in whom the greatest benefit may be realized with immunotherapies. Also important to note is that this trend regarding mortality and the timing of infusion held true for each of the 3 periods in the study when broken down by month.
With regards to antibody levels, lower rates of 7 and 30-day mortality were observed with the administration of higher antibody plasma. This also held true when accounting for time to transfusion of the various levels of plasma. Specifically, there was the greatest benefit observed at the extremes. In other words, patients who received high antibody plasma, less than 3 days from diagnosis to transfusion, had superior mortality rates to those who received low antibody plasma, greater than 3 days from diagnosis.
This study had several strengths and limitations. First, we'll start with the strengths. It's the largest study of its kind regarding the use of convalescent plasma therapy in COVID-19 patients to date and included 35,322 patients across 2,807 sites. Additionally, there was a level of built-in blinding and randomization given that in the antibody analysis, antibody levels in specimens were not yet known at the time of transfusion. And this study continues to add to the evidence that would suggest that if convalescent plasma therapy is found to be effective, then earlier administration, less than 3 days from diagnosis in this study, and transfusion of specimens with higher antibody levels are likely to lend to the optimization of the effect. As for limitations, the largest limitation of this study is the lack of control group or standard of care group. This does limit our ability to draw significant conclusions from the paper with regards to the overall efficacy of convalescent plasma therapy in the treatment of COVID-19. Additionally, though there was a sort of built-in randomization for antibody level, there was no formal process for patient randomization in this study. And again, some of this is artifact of the expanded access protocol and what an expanded access protocol is really intended to do and not intended to do. And thereby, use of an expanded access protocol makes optimal design of a clinical trial specifically relatively impossible. The study also didn't assess for pre-transfusion antibody status in patients receiving plasma transfusions, and one could expect that convalescent plasma therapy could have a greater impact on viral neutralization in patients who had not yet seroconverted. Thereby, it remains possible that a patient's baseline antibody status could remain an important factor as we consider convalescent plasma moving forward. There are some differences noted between the baseline demographics between groups, and again, this is due to the design of an expanded access protocol and would be difficult to circumnavigate, especially given trends in patient presentation and changes in management strategies over the periods in the study. And lastly, the use of the signal to cutoff ratio is a challenging marker to interpret within the context of not only a neutralizing antibody titer and also within the context of an SARS-CoV-2 specific IgG titer. It's likely that this type of qualitative test marker or qualitative test platform was used in order to allow for more widespread testing of convalescent plasma therapy donors in the future, and thereby potentially increasing the ability to quantify the plasma donated by some with regards to the measure of antibody level. However, as previously noted, most of the other studies examining convalescent plasma therapy and specifically looking at antibody titers in specimens have used neutralizing antibody titers or a specific IgG titer in order to quantify the antibody load of a specimen or a transfusion. So after reviewing the available data regarding convalescent plasma in the treatment of SARS-CoV-2 infection, I think it's prudent to review what we know and what we don't know. What we do know is that convalescent plasma has been historically used as a therapeutic in several other viral infections, including other coronaviruses, that data pertaining to the efficacy of convalescent plasma in COVID-19 is currently mixed and derived from small case series, a few small studies, and some open label, uncontrolled observational data, and that signals exist within this data that plasma may be most beneficial if administered as high antibody level transfusions early in the course of disease. What we don't know is if convalescent plasma is definitively effective when compared to placebo or other standards of care. We don't know how a recipient's baseline antibody titer may impact the efficacy of convalescent plasma. We don't know how optimal timing of the transfusion and what the optimal timing of a transfusion may be with regards to symptom onset. And we also don't know what the optimal dosing with regards to donor antibody titer levels and number of units to transfuse may be within the treatment of COVID-19.
Previous expanded access protocol criteria required patients to be greater than 18 years of age, have laboratory confirmed disease, and be admitted to an inpatient location with a life-threatening disease or the potential for progression to severe or life-threatening disease, and for those patients to provide informed consent. Severe or life-threatening disease was defined as the presence of dyspnea, a respiratory rate greater than 30, blood oxygen saturation less than or equal to 93% on room air, PaO2 FiO2 ratio of less than 300, lung infiltrates consuming greater than 50% of the lung fields within the previous 24 to 48 hours, respiratory failure, septic shock, or multiple organ failure. However, as of August 28, 2020, the National Expanded Access Program will be discontinuing enrollment, and patients may obtain access to COVID-19 convalescent plasma through the local blood banks through the emergency use approval as authorized by the FDA on August 23, 2020. It's important to note that there are some ongoing clinical trials, and if able, it will be important that patients be enrolled in convalescent plasma therapy clinical trials for COVID-19 as we continue to try to better understand the application of convalescent plasma in the more global landscape of management of COVID-19 patients.
The emergency use approval from the FDA specifically notes that convalescent plasma is approved for use in hospitalized patients. It's also important to note, though, that the expanded access program specifically employed plasma in patients with severe or life-threatening disease. Additionally, if plasma is effective, it would appear to be most effective early in the course of the disease, which again was defined as less than or equal to 3 days from diagnosis in the expanded access study. With regards to specific populations, convalescent plasma has not been evaluated in pediatrics, pregnant patients, or nursing mothers. There are no specific studies with regards to geriatrics, but geriatric patients were included in the data both on safety and efficacy that's emerged from the National Expanded Access Program. In order to be in compliance with the expanded use or emergency use authorization, a healthcare provider must provide the patient or caregiver with the FDA fact sheet, which can be found on the FDA website, and they also must notify the patient of emergency approval of the biologic and inform them that it's not formally FDA approved, notify the patient that they have the right to refuse administration, explain the known risks and benefits and the extent of which risk and benefit is currently unknown, and provide information on the availability of alternative treatments and their risk and benefit. The emergency use authorization requires that hospitals or healthcare providers must maintain records and conduct an investigation of adverse reactions observed after transfusion of convalescent plasma. Serious adverse events related to the administration of plasma should be reported to the FDA, and the emergency use authorization specifically states that fatalities must be reported pursuant to 21 CFR 606.170. Blood establishments are required to keep records of plasma collection and processing, including donor records, quantity of plasma processed, receiving site, and date of distribution. Hospitals are required to keep records regarding the receipt, storage, and administration of convalescent plasma, including donation ID number, quantity, receiving site, receipt date, patient who received the plasma, their age, disease manifestation, the number of doses administered per patient, and any other drugs that are administered. One major question that's arising as the practice and study of convalescent plasma administration in SARS-CoV-2 infection expands is who can donate and how. Current convalescent plasma donations are being processed through the American Red Cross and other participating FDA-registered blood banks. Per the FDA, these banks do not need to obtain any supplemental licensing or obtain their own IND in order to collect and manufacture emergency use COVID-19 convalescent plasma. They only need to follow their standard operation procedures and regulations for standard plasma collection and restrict collection to those donors who meet the eligibility criteria. Additionally, serum from donors must be tested for IgG levels using the ortho-vitro SARS-CoV-2 IgG test. Specimens with a signal-to-cutoff ratio of greater than or equal to 12 should be labeled and considered high antibody specimens. Specimens with a signal-to-cutoff ratio of less than 12 must be labeled low antibody specimens. Low antibody specimens may still be used at the discretion of the treating physician. Additionally, if blood centers are considering testing IgG antibody levels with alternative methods, they must contact the Center for Biologic Evaluation and Research to determine the acceptability of the proposed test. It would appear that if a center uses an alternative test that is not currently included in the FDA EUA to test IgG levels, they must label their specimens all as low antibody specimens. Determination of what platform is being used in local areas will be important to interpreting the labeling of the product received as you interpret whether it's a high or low antibody specimen. If additional tests are determined acceptable, specifically platforms are determined acceptable, then they would require an amendment to the EUA. And given the limited access to any one specific device, I suspect that this will be subject to change over time as local blood banks attempt to gain approval for their testing methodologies. Patients that are eligible to donate convalescent plasma must first be eligible to donate blood or other blood products by current standards. Additionally, COVID-19 convalescent plasma donors must have experienced both proven disease, as measured by a positive nasopharyngeal PCR at the time of illness or positive serologic test, and recovery, which is defined as a period of 14 days since the last symptom was observed. Note that a negative COVID PCR used to be required at the time of donation, and this is no longer required. Donors should also be HLA negative. It's going to be important as we move forward, especially as we gain more information and more experience with convalescent plasma and COVID-19, that mechanisms for donor screening and referral are optimized. Potential donors should be referred to either the FDA or American Red Cross websites or ccpp19.org, which is the website for the National COVID-19 Convalescent Plasma Project through Michigan State University. It's important to note that optimal dosing regimen for convalescent plasma in the treatment of SARS-CoV-2 is currently unknown. And a couple of factors have to be considered when we talk about the dosing of convalescent plasma. That includes the volume that's infused, which is typically referred to in units, where 1 unit is roughly 200 to 250 milliliters, and antibody titers. Both of these factors will likely impact the seroconversion of a host and subsequently the success of treatment. Historically, in much of the literature, neutralizing antibody titers were used to quantify the specimen. However, these are difficult to process. And as such, in the expanded access study, they used SARS-CoV-2 specific IgG assays to quantify their antibody titers. Additionally, in the emergency use authorization letter, the FDA indicates that blood centers will need to perform IgG assays and specifically use a signal to cutoff ratio of greater than or equal to 12 and label these as high antibody specimens, and use them preferentially to the lower antibody specimens, which would have a signal to cutoff ratio of less than 12. Even this considered, appropriate dosing remains somewhat of a moving target as the literature continues to evolve, so I expect this will continue to evolve as we gain more and more experience. But the current recommendation for dosing is a single unit of high titer plasma or high antibody plasma, and additional units of convalescent plasma can be administered at the discretion of the treating physician. The infusion rate for these products is being recommended at 500 milliliters per hour in most protocols, but patients with heart failure may require a prolonged infusion time or smaller volumes, given risks of transfusion-associated adverse effects.
With regards to the safety of convalescent plasma administration, most concerns hinge around the various infection risks which are possible. The first is antibody-dependent infection enhancement. This phenomenon has been described with other viruses, most notably dengue, where subneutralizing concentrations of circulating antibodies may suppress the innate antiviral system of the host. This would allow for increased intracellular growth and replication of the virus and a paradoxical worsening of the illness. This remains largely a theoretical concern with SARS-CoV-2, and the concerns stem from some in vitro models where they used monoclonal antibodies, which is compared to the polyclonal antibodies that would be found in convalescent plasma. It would seem unlikely, given the current experience with SARS-CoV-2 to date and other coronaviruses, that this would occur, but it should be considered. Secondly, concern has been raised for transmission and transfusion of active SARS-CoV-2 to an acutely ill patient. Theoretically, this concern could happen as a donor who had not completely recovered from the disease could transmit circulating virus to the recipient. But this would seem unlikely in that very low percentages, somewhere around 1% of symptomatic patients have been found to have circulating virus in the blood. Nonetheless, it's prudent to carefully screen donors to be sure that they are not actively infected. This is evident in the donor criteria requiring 28 days since complete symptom resolution or 14 days since symptom resolution with a negative PCR. Thirdly, there's concern regarding the transmission of SARS-CoV-2 to healthcare personnel. Again, if donation criteria were not strictly adhered to, it would remain possible that healthcare workers involved in the collection and/or processing of samples could be exposed to the virus. So strict adherence to donation guidelines will help to minimize this risk. Lastly, concern exists regarding the transmission of other infectious pathogens, given that this is a blood product. However, the risk of these pathogen transmissions, such as human immunodeficiency virus or hepatitis C or hepatitis B, is not really presumed to be higher than that observed with the administration of other plasma products in pre-pandemic times. And given current screening of donors, this is unlikely to be of significant concern. Adverse reactions that could happen with the administration of convalescent plasma are similar to those that would be observed with the administration of other blood products, predominantly fresh frozen plasma or FFP. Severe and life-threatening reactions are possible, including transfusion-related acute lung injury, which has been reported in the use of convalescent plasma administration in other viral illnesses, such as Ebola. This occurs relatively rarely at a rate of less than 1 case out of every 5,000 units of plasma that's administered. However, it could be disastrous in the case of a patient already in respiratory failure with COVID-19. So careful screening of donor specimens for HLA antibodies will help to mitigate this risk. Additionally, transfusion-associated circulatory overload may also occur, and though this has generally been associated with the administration of large volume of blood products. Current study protocols are only recommending 1 to 2 units of convalescent plasma, but that considered, it should be noted that the risk factors for transfusion-associated circulatory overload include advanced age and cardiac and renal disease, which also mirrors those who are at risk of severe COVID-19. Anaphylactic and allergic reactions are also possible, as with any blood product administration. At the first sign of any of these severe or life-threatening reactions, as manifested by signs of anaphylaxis, respiratory compromise, hypotension, significant changes in heart rate, or even at the judgment of the administering provider, current protocols recommend terminating the infusion. Non-life-threatening reactions may also include febrile, non-hemolytic, or urticarial transfusion reactions. These may be lessened by pretreatment with acetaminophen or diphenhydramine, and if they are observed, current protocols recommend slowing the rate of infusion. Recently, data has begun to emerge from the National Expanded Access Program for convalescent plasma in the treatment of COVID-19. The data released is from April 3rd to May 11th of 2020, during which 14,288 patients were enrolled in the program, with 8,932 receiving transfusions. The data details the safety of convalescent plasma from the first 5,000 patients. With regards to serious adverse events within 4 hours, there were 36 events observed from the 5,000 infusions. This included 15 deaths, 21 non-deaths, which were made up of 7 transfusion-associated circulatory overload cases, 11 transfusion-associated lung injury cases, and 3 severe allergic transfusion reactions, all making up only a fraction of 1% of total transfusions. Mortality at 7 days occurred in 602 patients, or 14.9%, as estimated using a Kaplan-Meier product limit estimator. Further separated by ICU and non-ICU, you can see mortality rates of 16.7% in ICU-admitted patients and 11.2% in non-ICU admitted patients. Given that this was only a review of the safety of convalescent plasma and not specifically designed to assess efficacy, the authors caution readers on over-applying this data with regards to efficacy in the treatment of COVID-19. There are not a significant number of drug-drug interactions to be observed with convalescent plasma therapy. However, given that convalescent plasma is essentially FFP from a patient previously infected with SARS-CoV-2, it does have the potential to interact with the INR of patients anticoagulated with vitamin K antagonists. The dose of FFP given for warfarin reversal is generally related to the pre-admission INR, but a typical dose of 10 to 15 mils per kilogram is given for reversal of supratherapeutic INRs. In a 75 kilogram patient, this would equate to roughly 3 to 5 units. This is notably higher than the doses that are being used in the current convalescent plasma protocols. However, as pharmacists, we should note that the administration of convalescent plasma may impact the INR in patients receiving warfarin. The INR should be monitored in this scenario with appropriate bridging with alternative anticoagulants if reductions in INR are observed. Here I've detailed for you a few resources if you're looking for more information on convalescent plasma use in COVID-19. Specifically, the FDA release, American Red Cross, ccpp19.org, and uscovidplasma.org all have great resources for those who may be candidates for donation of convalescent plasma. In summary, the mechanism of convalescent plasma administration for the treatment of COVID-19 is the transfusion and transfer of passive immunity. The data is limited to evidence from other coronaviruses, small studies and case series, and experience from the National Expanded Access Program. Donors should have confirmed infection with recovery for 14 days prior to donation, and recipients should enroll through either a clinical trial or may receive the product through an emergency use authorization and the EUA from the FDA. The product is supplied by participating blood banks. The dosing is 1 to 2 units or 200 to 500 milliliters of high-titer convalescent plasma. And with regards to safety and adverse effects, infection risk and typical blood product concerns remain the primary issues to be aware of. Drug-drug interactions, you may see a theoretical lowering of the INR for patients on warfarin, given that this is basically plasma or FFP that we're administering, although this remains somewhat theoretical to date.
I hope this has been a helpful review of convalescent plasma and its role in the treatment of COVID-19. We have received a lot of literature, and a lot of literature has emerged on this topic since the beginning of the pandemic, and I suspect this will continue to be the case as we move forward. Much remains to be determined, including the efficacy, further information around the safety of the therapy, and then specific populations which may be most likely to benefit. So future research and enrollment in clinical trials will be critical as we move forward and continue to explore the use of convalescent plasma in the treatment of COVID-19.